All right, terrific. So I skipped my first slide. So I just thought I'd start with some background slides. Just to mention that tricuspid valve regurgitation is very prevalent, and it actually increases in prevalence with age. It's actually more than aortic stenosis. And I think these patients are in our clinic right now. So if you look at all these patients that are getting TAVI, 20% of those patients have severe tricuspid regurgitation, and such is the case in patients with dilated cardiomyopathy and also surgical aortic valve replacement. We also know that TR is associated with bad outcomes and reduced survival. And in fact, you can see the gradations as the severity of TR increases, so does the mortality. So I think there is a real relationship here in terms of the severity of TR. And this holds true even in patients who do not have significant pulmonary hypertension. So even in patients who have PA pressures less than 40, you can see this impact of the severity of TR on survival. And the same thing holds true for patients who have ejection fraction more than 40% or 50%. So here is, some of the numbers. So you've got lots and lots of patients with tricuspid regurgitation. You've got very few TR surgeries. Almost, if you look at the number of patients that are being treated, it is less than 0.5%. So if you look at the outcomes, why is this not advancing? All right. So here are some of the transcatheter devices. A lot of these have actually already been phased out, or some of them have actually been phased out, but a lot of these are actually modeled after the surgical techniques. I'm going to talk a little bit about the clip, but actually spend a lot more time on the valve replacement. And, we've done patients like this. A lot of people, this is the off-label use of a clip. Here is a young patient with heart transplant, flail after biopsy, severe tricuspid regurg. She was transferred on pressors to our hospital. In fact, we put 2 clips here, off-label, reduced the tricuspid regurg, and she did great. So what's the data with off-label? And this is one of the publications. So there is reduction in TR, but if you look at it, almost 1/3 or more than 1/3 of the patients still have severe tricuspid regurgitation. So while it is effective, there is still a lot of room for improvement. And the same study also showed that whenever patients had procedural success, their chance of survival was actually much better when they actually had procedural failure. So this is an indirect evidence that fixing tricuspid regurgitation might have an impact on mortality. So the dedicated device, so the clip is the same, but in fact, those of us who've done off-label use of the clip know how hard it is to become coaxial to the tricuspid valve, and it is a struggle. So the dedicated system is use the TriClip or the TRILUMINATE, the early experience, and here are some of the baseline characteristics. But when you look at the summary of this, what is clear is that the success rates were actually high, the procedural success rates were high. If you look at the 1-year data, the durability is actually not bad. And if you look at the number of clips that were used, were 2.2, and there was improvement in quality of life. KCCQ scores were up by 20 points. I think this is the most important study, the TRILUMINATE. It's the randomized clinical trial, which is in the final phases, I would say. I think in the last quarter of its enrollment and randomizing patients between clip and medical treatment. And I think we will know a lot more once the results of this are released. So what are real-life data? And these real-life data were just, using the TriClip from Europe, just at the recently concluded London Valves. Once again, these are non-selected patients, and what you can see here is that, once again, 66% of the patients had moderate or less tricuspid regurgitation after undergoing a TriClip system. So I think these results are very similar to what I've actually shown earlier, with similar impact on KCCQ and NYHA clasp. And also similar data are present for the Edwards device, the clasp. and I mean, much fewer patients. So there's only 63 patients. And once again, if you look at the reduction in TR, it seems to be, once again, quite similar to what we've actually seen with the edge-to-edge repair with the clip, with similar improvement in the functional class. So once again, the CLASP II trial is also ongoing. So this is a randomized comparison of the Edwards system, the Pascal system, compared to optimal medical treatment. I think this is where the excitement is, the valve replacement. And these are different valves that have had some experience in humans. And I'm going to talk to you a lot more about the EVOQUE valve, which is what we've been involved with at our institution. So this is what the EVOQUE valve looks like. It's available in 2 different sizes. And this is a percutaneous system, through the vein. No cut down is required. And essentially, you're advancing the system over a safari wire in the RV apex. And this valve anchors by latching on to the cords, the leaflets, and also essentially anchors into the annulus. So I will go ahead and show some slides. So here is a patient, with severe tricuspid regurg, as you can see. And this is one such patient that we enrolled in the EVOQUE tricuspid study. CT scan is absolutely critical. And here is a patient who actually has a pacemaker. So in fact, 1/3 of the patients that we've enrolled in the EFS actually have had pacemakers. So CT planning is absolutely necessary. So this is some of the steps. You can see this is advancing the system, very much dependent upon the echo guidance. All right, so this is very image intensive. Otherwise, the steps are rather very simple. And as you can see, the anchors coming out, and gradually over a period of steps, the anchors are flipped. You're expanding the valve. And this is actually the release of the valve. So you can, this is a fairly stable procedure. On an average, takes about an hour. And very reproducible. So here is the result here in this patient: complete elimination of tricuspid regurgitation. The EVOQUE TRISCEND pivotal study is randomizing patients right now in a 2-to-1 fashion to the EVOQUE valve versus optimal medical treatment. And in addition, there is actually a registry that is enrolling patients who are not considered to be suitable candidates for randomization. And these are the study outcomes. So there will be 30-day outcomes, but 6-month tricuspid reduction, and of course 12-month looking at some of the hard clinical endpoints and some of the quality of life issues. So, what I showed you is a very typical example, no cherry picking. I mean, it is very striking, to see most of these patients. So here is yet another example, and you can see, look at the tricuspid regurg at baseline and look at it after tricuspid valve replacement, and you can see the follow-up and the follow-up CT. The valve is very nicely seated, and here is conduction system issues can occur, and here is actually a case where we've gone through the tricuspid valve, and actually we have implanted a MICRA device in this patient, and here what it looks like. So the pacemaker requirement can be about 10% in these patients. So, here are the data that were presented by Sushila TCT, and then we presented them at the London Valves. So these are patients, 132 patients with valve replacement in the EFS study. The average age is 79. You can see most of these patients had severe tricuspid regurgitation. 90% of these patients had atrial fibrillation. 80% of them had pulmonary hypertension of some degree. Most of this was functional tricuspid regurgitation in 70% of the patients, and 35% of the patients actually had pacemakers. So you get a flavor of these patients. All of these procedures were done percutaneously with 100% procedural success rate. Or you can see actually 96.2% procedural success rate. The length of stay was 3 days. Most of this was to optimize the volume status. And if you look at the mortality, it was 2.4% at 30 days. And bleeding is not uncommon in these patients, and partly because patients are on anticoagulation, and these patients have a lot of mortality. And the new pacemaker rate was 10.5%. If you look at the tricuspid regurgitation, you can see how the rates are at 6 months. So 100% of the patients had mild or less tricuspid regurgitation at 6 months, which is not very different from what it was at discharge. So these results are actually very, very durable. And if you look at the composite major adverse events, you can see that after the first 30 days or so, the curve is pretty flat. So there's not a whole lot of adverse outcomes, after 30 days. There is 97% survival and 95% freedom from heart failure hospitalization in these patients. And look at the quality of, life scores here. There's a 27% increase in KCCQ scores, and 90% of these patients were actually in NYHA class 1 and 2. So if this is a preview of what we will see in the, in the pivotal study, then I think we are going to have something very, very useful to treat our patients. So I think what I thought I would do is very quickly show you a last case. And I think this is the future, right? So this is a patient with severe mitral regurgitation. And we enrolled this patient in the M3 trial, and, we did a percutaneous mitral valve replacement. This is installing a dock first and then doing a transseptal valve replacement. So, and we got a great result. A year later, the patient developed symptoms again, had tricuspid regurgitation this time. And in fact, we were able to enroll this patient in the tricuspid study. So you can see now that there is a tricuspid valve also. So here is a patient who has percutaneous mitral valve replacement and tricuspid valve replacement and is actually so far doing great. So I'll go ahead and end my talk with that. Thank you.